I would like to thank the organizers for letting me talk. I have a very limited time and a lot to tell, so I better start for the sake of time. In this talk, I will review some of the CNS tumor treatments for this year's update. I would like to be as modern as possible. We'll emphasize only the latest literature. So I have picked three topics. The first one will be the new updates in gliomas. The second will be the overview of the treatment of brain mets. And the third one will be, if I have time, overview of the treatment of meningiomas. So let's start with the glial tumors. So the most recent update in glial tumors is the WHO 2021 classification, because the pathological diagnosis that we knew until that time, until 2021, is totally different now. And it's majorly based on the molecular evaluation of the patients, of the tumors, and the main classification depends on the IDH status. So if the tumor is IDH wild type, we molecularly usually define those tumors as molecular glioblastomas, where on the other hand, if the tumors are IDH mutant, although they are grade 4, they are classified as ADH mutant astrocytomas, and those are the final molecular and morphological pathological diagnosis. Why IDH mutation is very important? Because IDH mutations are associated with better prognosis, and we know it very well from different clinical trials. There is a major difference in the long-term overall survivals with the IDH mutated patients versus IDH wild-type patients. The second important thing on survival is the extent of surgical resection. This is a very recent paper from UCSF, and they have done an RPA scaling, looking at not only the pathology but also the surgical resection, and grouped the gliomas in 3 groups. And the best overall survivals were in the good molecular pathology, and which has a very small residual postoperative tumor volume, where on the other hand, if the patients are only biopsied, irrespectively from the pathology, they have the worst overall survival. One of the trials that I would like to emphasize is the RTOG 9802. This is a randomized trial looking at the impact of addition of 6 cycles PCV chemotherapy in high-risk, low-grade gliomas, where the definition of high-risk is age greater than 40 years old, and the patients which have subtotal resection or biopsy only. Although this is a very old study, as the events in low-grade gliomas take time, it has been recently published in New England Journal of Medicine. The first thing that we have learned is the addition of PCV chemotherapy increases overall survival compared to radiation alone, but also it again emphasized the importance of IDH mutation irrespective of the patients receiving therapy. And the IDH mutation was also predictive for the addition of chemotherapy. The patients which had the IDH mutation benefited from the PCV chemotherapy more than non-mutated patients. And so this was emphasized in a follow-up paper. The adjuvant PCV benefits IDH mutated diffuse gliomas regardless of the 1p19q co-deletion, which is a predictor of the oligodendroglioma diagnosis. The patients having IDH mutated tumors, irrespective of 1p19q co-deletion, benefited from PCV chemotherapy. The second trial, parallel to the RTOG, was the EORTC trial, where again included high-risk low-grade gliomas, and the randomization was between radiation therapy and temozolomide only. And the initial publication revealed no difference between radiation and temozolomide, which is a different standard than what we're doing in high-risk, low-grade glioma patients right now. But what we have learned again is the importance of IDH mutation, and the patients, the tumors which were IDH mutated and non-code-deleted, treating with only temozolomide is not a very good option. You have to combine it with radiation therapy. The second clinical trial that I would like to emphasize is the CATNON trial. It actually started before this WHO classification, so this is irrespective of IDH status. That was a 2x2 factorial design looking at the benefit of adding adjuvant temozolomide to either radiation alone or radiation with concurrent temozolomide. The 2019 publication revealed again the impacts of IDH, and the IDH mutation status had a stronger correlation with overall survival compared than MGMT methylation alone. Although MGMT methylation was again important, IDH mutation was more important. And what more we have learned is for the patients that had IDH mutation, also had the MGMT methylation as well. And additionally, that was the addition of adjuvant temozolomide. And what we have learned is the patients which were IDH wild type did not benefit from the addition of adjuvant temozolomide. So they should be classified as glioblastomas, where on the other hand, patients which had IDH mutant tumors benefited from adjuvant temozolomide. The second analysis was to look at the effect of adding concurrent temozolomide to standard radiation in grade 3 astrocytomas and aplastic astrocytomas. Although there was a trend, still the addition of concurrent temozolomide is not validated, but probably with the long-term follow-ups, the addition of concurrent temozolomide in this patient population will benefit in terms of overall survival. However, the patients which were IDH wild type did not confer an overall survival benefit with the addition of concurrent temozolomide. So patients which have IDH wild type tumors do not benefit from alkylating agents therapy. So this is a summary of the treatment of diffuse gliomas. There is a window of doing nothing after gross total resection versus doing concurrent chemoradiation followed by chemotherapy, and this has to be personalized according to patients' clinical and neurological status and the molecular profiling, because some of those patients will be living for a very long time, so we have to take care of the long-term side effects of our standard treatments. One of the most important papers that was published in this year was looking at the effect of anti-IDH 1 and 2 targeted drugs for the sake of delaying radiation or surgery for patients which were operated and followed up and recurred with a diagnosis of low-grade gliomas. That was a perioperative phase 1 trial, which was published in Nature Medicine this year. And this will be proceeding with a phase 3 randomized trial, which is still ongoing. The ASTRO published clinical practice guidelines for the standardization of radiation treatment in terms of contouring and treatment and planning details for the grade 2 and grade 3 diffuse gliomas as a guideline. It gives feedback of how we need to proceed with those patients' radiation therapy. One of the most important updates is the response evaluation. The Neuro-Oncology Society published the RANO criteria first in 2011 to standardize the follow-up procedures for the patients who were treated with gliomas. This criteria has been updated this year with RANO 2.0 for high-grade and low-grade gliomas in adults. It's published very recently. The second group of patients that I would like to emphasize for primary gliomas is obviously glioblastoma. This is another molecular subgroup of patients which has a poor prognosis and a worse overall survival with more affecting radiological effects. Obviously, we know this very well. This is the standard STOOP trial where the addition of concurrent temozolomide to standard radiation therapy and the addition of 6-month adjuvant temozolomide became the standard. I don't want to spend a lot of time, but what we have learned from the STOOP trial, the importance of MGMT status, irrespective of IDH status, because in those patients, because this paper was published in 2005, probably included IDH mutated tumors as well. What we have learned is the patients which doesn't have an MGMT methylation did not benefit from dose escalating temozolomide. So the alkylating agents will not affect those patients as well, but those who are methylated have better overall survivals. One of the important clinical practice changing trials was this EF14 trial, which included tumor treating fields to the STOOP trial, which has become the standard. So it basically inhibits the progression of the tumor cells with the electrical fields. The patients wear it as a cap during the adjuvant temozolomide period for maximum 2 years for at least 18 hours per day. And the addition of this tumor treating fields increase overall survival, both in MGMT unmethylated and methylated patients, where on the other hand, the ones who were MGMT methylated benefited more from the electrical fields. The standard contouring and planning guidelines for glioblastomas is published both by Astro and EANO very recently. It gives information about how to do the contouring and some critical structure dosimetry as well. 2 new papers were published this year, looking at the benefit of addition of immune checkpoint inhibitors to standard therapy, both in newly diagnosed and recurrent glioblastomas, where the checkpoint inhibitors did not have any effect when added to the standard protocol. So it's not recommended to be used outside of a clinical trial. The last paper that I would like to emphasize is this CTEC-NOA trial from the European colleagues, looking at the addition of adding lomustine to patients who were MGMT methylated to the standard STOOP protocol. The patients that were included in this clinical trial was very low, but there was a trend towards a survival benefit with the addition of CCNU to standard protocols. But it is a toxic drug, so it has to be personalized according to the patient's clinical situation. The role of reirradiation for recurrent GBM was analyzed in a phase 2, a randomized trial, and it has been published very recently. Bevacizumab alone versus hyperfractionated reirradiation plus bevacizumab was compared, and there was no addition of reirradiation, so it's not recommended outside of a clinical trial anymore. Although the progression-free survival seems to be better, again, it has to be personalized according to the patient's clinical situation. So the second topic that I would like to discuss is the brain metastases. The most important thing to decide how to proceed with the treatment of brain metastases has to be looking at the prognostic scoring, which is called GPA. It is a scoring system looking at different clinical information and the primaries and giving you a scoring system and a predicted survival so that you decide how to proceed with brain metastasis. And taking this GPA into account has been recommended within the ASTRO guidelines as well. And this is a web-based application that you can find it and you can use it for your patients deciding how to treat your brain metastases. There are several treatment options for brain metastasis, and the factors that is affecting the treatment selection depends on various factors, especially the location, the size, the symptoms, and the need for tissue diagnosis. But one of the most important things as a radiation oncologist that we have to keep in mind that not all of those brain metastases, surgery is an option. This is an EANO guideline recommending SRS as a less invasive option for surgery if the patients do not need surgery, because surgery for brain metastases are not enough because they're recurring locally, like by two times more than any type of radiation. So we need to proceed with some sort of a radiation after the metastasectomy. The cavity SRS is an option for proceeding for radiation after metastasectomy, and it has been compared in a phase 3 randomized trial and was published. This trial randomized SRS to surgical bed versus whole brain radiation after brain metastasectomy. There were no differences in survival. With the addition of whole brain radiation, there was worse cognitive function, but the local controls were better with whole brain radiation compared to SRS, cavity SRS. So we need to decide the need for surgery for those group of patients. And leptomeningeal carcinomatosis is another issue after metastasectomy, so we need to take into account this issue. I am skipping those. Another option to decrease the amount of local recurrences, radiation necrosis, and leptomeningeal disease could be the use of pre-op SRS versus post-op SRS. And there are ongoing phase 3 randomized trial. Still, we do not have any information about it yet. Whole brain radiation is another good treatment option for patients who we need to proceed with whole brain radiation, but we know that whole brain radiation has a worse cognitive impact on the patients. So the best way to avoid this is it has to be adding hippocampal avoidance whole brain radiation therapy plus memantine, and this has been validated in a phase 3 randomized trial. So out of every 10 patients, 6 patients can be spared in terms of neurocognition if we add hippocampal avoidance and memantine to whole brain radiation. The comparison of SRS with whole brain radiation has been done in numerous phase 3 randomized trials, and the overall survivals were the same. And we know that if this is a meta-analysis of those 4 more phase 3 randomized trials, when the patient is young at age, proceeding with...
Professor, you have got 2 minutes only.
Sorry?
You have got 2 minutes.
Yeah, I'm just about to finish. The addition of the use of SRS compared to whole brain radiation has more effect. And the last topic that I would like to emphasize is delaying radiation for brain metastasis with the use of systemic therapies, and especially with targeted therapies that can be penetrate to CSF better compared with standard cytotoxic chemotherapy. This might be a good option. And this has been recommended in the latest ASCO SNO Astro guideline for the patients receiving anti-LAK and EGFR, as well as immunotherapy. If the tumors, if the metastases are small and non-symptomatic, the use of radiation can be deferred. So I'm skipping meningiomas, and as a summary, CNS tumors require multidisciplinary treatment approach. Careful patient selection requires balancing outcome and potential toxicity. There are increasingly new treatment approaches, and we need to personalize those treatment approaches. Despite significant advances in molecular biology, still we need novel approaches, especially for the bad biological prognostic tumors. Thank you for your attention.